All right, so we're going to shift gears and kind of maybe start a new project here and have some case studies that have a 12 lead attached to it and some details about our patient and kind of talk our way through it. So here's your patient, 60-year-old homeless man. So you and a student are paged to assist an engine company on scene. So you get to the scene about 3 hours earlier. He had started to experience some chest pain and shortness of breath. So he rated the pain at a 9 on a 10 scale. So chest pain was 9 out of 10. It radiated superiorly up the center, as he said, of his chest. Patient reported associated nausea and stomach pains. So he was recently released from a local emergency department after being ruled out for an MI. So when you got there, paramedics from the engine company had already established an IV line and administered sublingual nitro according to their protocol. When you arrive at the scene, the patient is unresponsive and he is supine. So here's some information about him. He had chronic chest pain. He has a history of alcohol abuse as well as pretty much untreated diabetes. Patient, he's non-compliant with his meds. He's supposed to be taking aspirin, lisinopril, HCTZ, insulin, and metoprolol. He has no known drug allergies, as well as the vital signs we get when we get up on scene is because this was post nitro. He had a blood pressure of 77 by palpation, had a pulse rate of 100. He had and it was irregular. He also had a respiratory rate of about 16, and he was satting at 88%. So that's what we're looking at. When we take a look at him, we see a disheveled male patient who's supine on the ground. So he moans in response to painful stimuli. His heart sounds are irregular. Lungs are clear bilaterally, no lower extremity cyanosis or edema. Radial pulses are absent bilaterally. There is a strong and irregular femoral pulse, and as well as his skin is cool to the touch. All right, so let's first start taking a look at our 12 lead here. We've got some things that kind of stands out to us. Now, right away, we know we want to go ahead and find out what our rhythm is, right? So when we just poke around pretty quick, it'd be nice to have, many of them have a nice continuous lead to or whatever lead you chose, but down here, we don't have that. But let's remember our rules for atrial fib. Number 1, no discernible P waves. Number 2, positive or the presence of fibrillatory waves or F waves, as well as irregularly irregular. So when we look just right here, we see what appears to be fibrillatory waves. We also do not find a discernible P wave anywhere throughout the 12 lead. And it appears that we do have fibrillatory waves. So let's go ahead and so we're going to go ahead and we got a fib. Now, we got a rate of 100, so go ahead and say, hopefully you remember RVR, atrial fib with RVR, rapid ventricular response. That's what we're talking about. Because it is an AFib, it's irregularly irregular. So there's going to be times where this is 130, 140 beats, and sometimes where it's going to be 100. So it's a lot of different kind of big area. So let's go ahead and take a look at our 12 lead. So you guys know, if you've watched my stuff, the way that I like to do it, I'll start here, 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 and here, and then go for inferior, then go septal, and then go anterior. So knowing that, let's go ahead and look for if we find any elevation in lead 1. We do see some depression, right? It appears to be some depression. AVL as well has depression. 5 and 6 appear to be pretty normal. Leads 2, 3 in AVF. For our inferior, it appears that we're going to have some elevation, a lot of elevation here. And we go over to AVF, and yeah, that's kind of off the chart, isn't it? Then we move on. We start looking in our septal area. We start to see V1 and V2 and V3 with some depression. It's really just starting here in V1, but we see it in V2, V3, V4. Now, we didn't talk, I may have mentioned this in some of the other ones, but we don't really get into it in 12 lead. But ST depression in V1, V2, even V3 and V4, when we start talking about the anterior wall and portion of the heart, we can start thinking about a possible posterior MI. But the way that we have to do, what we do to confirm that is we need to exchange the electrodes onto their backside to run a 12 lead to look at the posterior wall. So anyways, we see that leads to V2 through V4. They demonstrate some ST depression with some prominent R waves, and that is highly suggestive of extension of the infarct into the posterior wall. So we already know that we've got this here, right? We already see that we can expect inferior MI is what we're thinking. And then we see the depression in 2, 3, and 4, in V2, 3, and 4. So reciprocal changes are evidence in lead 1. Right here's what we're talking about, and lead AVL as well. So while you're dealing with them, he became unresponsive, and this was not why you were dealing prior to your arrival. Unresponsive and hypotensive after the administration of nitro. So you start high flow O2, prepare the patient for rapid transport. Now his lungs are clear, and his pulse ox improves with gentle airway positioning and high flow O2. So let's go ahead and we want to give him some fluid because we've got kind of a bad blood pressure, right? First thing we want to do is make sure they're fluid resuscitated. Before we start thinking about a vasopressor, we want to make sure that they are fluid resuscitated. So I think probably the best thing that we would want to do is go ahead and give them a bolus. Don't you agree? So we administer a bolus of normal saline, wide open. We give them no further doses of nitro. As well as our student asks, hey, what do you think about dopamine? What if we started dopamine at 5 mics per kilo per minute? But after we gave that fluid, so we gave him about 1.5 liters of normal saline. After we gave him that fluid, we went ahead and rechecked his blood pressure. Now we have a blood pressure of 92. So that's after about a liter and a half of saline. So an infusion of dopamine is not required. So he becomes more alert and cooperative. Student provider goes ahead and gives him 324 chewable aspirin, and we decide that we're going to take this gentleman to a cath lab. So while we're on route, we don't have a copy of it here, but while we're en route, because as we've talked about, we have an inferior MI. And we know that when we have an inferior MI, somewhere around the neighborhood, I think the number is 40%, could be having a right-sided MI, right ventricular. So we go ahead and run a right-sided MI as well, confirm the presence of right ventricular involvement. So the way that we do that, we know that we see elevation in 4. You can sometimes see it in 5 and 6 as well, really depending upon the damage. But you're definitely wanting here, so you'll see V4R. And that was our case. So once again, we're looking at our 12 lead. We saw depression here. We saw elevation, elevation, elevation. What do we see here? Looks like some depression, as well as this depression here, which, like I said, kind of starts making us think about posterior wall. So that's the case. We'll probably start knocking some of these down, and you guys can go through them, and hopefully it's going to give you a little bit more exposure to these 12 leads and kind of tearing them apart and kind of putting a patient with it. So hopefully that was at least a little bit, probably enjoyable may not be the right word, but useful, let's say that. So we'll talk to you guys soon.